Good morning, this is Dr. Sohrab Gollogly in Monterey, California. I'm a microscopic and endoscopic spine surgeon with a real interest in outpatient minimally invasive spine surgery, and I'd like to share a recent clinical case with the endoscopic treatment of facet arthropathy and a facet joint in a combat athlete, and here I'd like to let Cub Swanson speak for himself.
Hey, what's up? I'm Killer Cub Swanson. I'm a UFC fighter. Been fighting for 20 years, and I've been at the highest level with the UFC for 17 of those years. So I've had multiple broken bones. I've really, pushed my body to the limits. But one thing that's always bothered me is my back, my lower back. And, with lifting weights and doing the things I do, I got to the point where my lower back pain was starting to become unbearable. And the UFC sent me to one of the top doctors in the nation in LA. And he basically said, well, you're not a candidate for a fusion or a disc replacement, but if you download my app and do my exercises, then I think you'll be okay. That really rubbed me the wrong way because I was in a lot of pain. I said, look, sir, I have a broken rib right now and a broken hand. And I walked in here, I don't have a cast on. I'm not on any painkillers. This doesn't bother me. I'm tough. My back really hurts, and I'm trying to express that to you.
So here's Cub's initial MRI scan, which demonstrates facet arthropathy worse on the right side at the L5-S1 level with a facet cyst on the medial aspect of the facet complex and a small annular tear at the back of the L5-S1 disc. His presenting symptoms were low back pain and buttock pain radiating into the left leg and limited range of motion of the lumbar spine and hip, which was especially restrictive for someone who's a combat athlete.
So he ordered another CT, bone scan, and MRI, and come to find out I had a couple disc issues, nothing too crazy, but I had bone spurs and I also had a cyst pushing on my sciatic nerve that was just driving me crazy.
These are the results of his bone scan with SPECT CT, which demonstrates a very remarkable degree of asymmetrical activity in the facet complex on the right side at the L5-S1 level, which corresponds perfectly to the degree of facet enlargement seen on the MRI scan and also the location of the cyst. Clinically, at this time, the patient received a series of periarticular steroid and local anesthetic injections, which allowed him to continue training and ultimately fight. And then after that fight, his back pain got to the point where he couldn't train any further, and he ended up seeing me. At the time of his repeat scan, so this was the scan that was done immediately before his operation, the cyst had decreased in size, or at least wasn't captured as perfectly on one of the slices of the MRI scan. His annular tear was still visible. But my decision at this point after a physical examination was that his pain was coming primarily from the L5-S1 facet complex on the right side, and I chose to endoscopically treat both the medial aspect of the facet joint by resecting the facet cyst, and then also perform a medial branch transection at the same time in the same setting in order to be able to take care of the arthropathy coming from the facet joint itself. This is the endoscopic view of looking into his spinal canal, and this is one of the things that I've been able to appreciate with the endoscope, where here you can see the facet cyst, the traversing S1 nerve root, and then very importantly be able to palpate endoscopically and release the adhesions that develop between that inflammatory cyst and the edge of the nerve root. So at this stage in the operation, I've docked the cannula partially through the ligamentum flavum, and I'm using an endoscopic freer to be able to mobilize the S1 nerve root medially away from the facet cyst. And you can appreciate the filamentous and spiderweb-like adhesions that have developed between the edge of the S1 nerve root and the facet complex, which in my opinion is an extremely common source of discomfort because it creates a stretch neuropraxia every time this particular athlete tries to use his hip and his lumbar spine to the limits of his range of motion. And so what I'm doing now is rotating the cannula and going inverted, looking back towards the lateral wall and visualizing the facet cyst. And then there, superior to the facet cyst, are the remainder of the adhesions between the edge of the nerve root and the facet complex. and then I'm stretching them with the tip of the cannula and then using a bipolar device in order to release them, coagulating any vessels that are inside of them, and then finally releasing them completely with scissors. And it's this stage of kind of in situ neurolysis of the adhesions that develop between inflammatory processes inside the canal and the adjacent neurologic structures that can be visualized better with endoscopic techniques than with microscopic techniques, because we are operating in a completely aqueous and atraumatic environment. Here I'm releasing the facet cyst with a kerrison rongeur, so there's the characteristic signal of facet fluid inside the cyst itself. And then I'll use a bipolar device to shrink the facet cyst up against the wall. And then here, at the conclusion of the case, is the S1 nerve root now free from the inflammatory process on the lateral wall of the facet complex, visualized nicely inside the canal with an endoscopic technique. Here's his
Probably
final.
the easiest surgery I've ever had. I've had multiple. And I could say that I'm back to doing everything. I'd say within 6 weeks I was going almost without worry, but 8 weeks I stopped worrying about it. And I'm back to doing the things I love to do. It doesn't hurt to play with my kids, and I'm back in the gym training my guys, and I'm ready in case I want to take another fight.
So in general, what I would consider to be a great result in a very active athlete for whom traditional spine surgery wasn't appropriate. And in this case, I performed both a medial transection and an in situ neurolysis of the S1 nerve root, resecting the facet cyst from the medial aspect of the facet complex. Any questions, please feel free to get in touch. Sohrab Gollogly, MD.com.